Ladies and gentlemen, I am Dr. Wang, the Chief of Uro-Oncology Center, Changhua Christian Hospital, Taiwan. It's my great pleasure and honor to give the talk about the diagnosis and treatment of prostate cancer. The presentation will be conceptual and based on scientific evidence. Prostate cancers are very common in aged males. It becomes an important healthy issue for those with aging society structure, especially in developed countries with high aged male proportion. The risk factors for sure are old age, race, and genetics, and there is no effective ways of prevention so far. The diagnosis of prostate cancer should be based on serum prostate-specific antigen, so-called PSA level. For some cases, PHI, prostate health index, digital rectal examination, and pathological confirmation. Prostate tissue is usually gained by biopsy or surgery. Biopsy can be performed transrectally or transperineally and guided by ultrasound, MRI, magnetic resonance image, or ultrasound MRI fusion technique. Prostate cancer grades are described according to the Gleason score, from 1, the normal, to 5, the highest grade, distinct patterns. 1 Gleason grade to the most predominant pattern, and a 2nd Gleason grade to the second most predominant pattern were assigned. In 2014, the International Society of Urological Pathology released supplementary guidance and a revised prostate cancer grading system called the Grade Group 1 to 5. Staging is following the TNM system: tumor, lymph node, and metastasis. The definition of substaging from T1 to T4 are described as on the list. Clinical T1 and T2 are categorized as localized diseases. Those with lymph node metastasis, T3 or T4, would be considered as locally advanced diseases with worse prognosis, higher recurrence, and metastatic rate after definite treatment. It's essential to classify the biochemical recurrence risk of every prostate cancer by 3 things. That is PSA, Gleason grading or grade group, by ISUP, and clinical stage. By EAU, Association of Urology, those who are considered with low risk should be limited within those PSA less than 10 nanogram per milliliter, Gleason score less than 7, ISUP grade group 1, and clinical stage of T1 and T2A. The high-risk group would have any one of or more of the following factors: PSA more than 20 nanogram per milliliter, or Gleason score more than 7, or locally advanced disease. That is any PSA, any Gleason, but clinical T3, T4, or lymph node positive. And the others will be in the intermediate risk group. Some subclassification of very low, favorable and unfavorable, intermediate, and very high risk groups are designed for better prediction of various prognosis. Now, staging workup basically depends on MRI and bone scan. For certain purpose, CT, computed tomography, and PET scan, positron emission tomography are helpful. The treatment decisions are based on age or life expectancy, risk classification, clinical staging, surgeon physician's expertise, institutional facility, patient's comorbidity, patient family's situation, and then the goal of curative intent or only life-prolonging purpose. For low-risk disease, active surveillance should be considered, especially for the really old age patient. Treatment options include radical prostatectomy, RP, with or without extended pelvic lymph node dissection, or with or without nerve sparing. Radiotherapy, RT, high-intensity focused ultrasound technology, so-called Pai-Fu, and cryotherapy. This is the video of radio-sparing robotic-assisted radical prostatectomy performed by myself at Changhua Christian Hospital. This is the retrovesical space. As you can see, I already dissect the prostate bilateral, and this is brain neck. Now I'm opening the brain neck to take away the prostate from the urinary bladder. This is urinary bladder, and this is prostate. We need the assistant to use the suction tube. As you can see now, the brain neck is open, and we can see the Foley's catheter. Now we put the Foley's catheter out, and you can see the small brain neck as I preserve. For localized disease or low-risk disease, if you preserve the brain neck as well as possible, the risk of incontinence, post-operative incontinence, will be decreased. And then I enter the anterior surface of the prostate, and then we encounter the dorsal vein complex. So we can perform a suture ligation of the dorsal vein complex to decrease the blood loss. We'll suture along the plane of dorsal complex, and then we continue to cut the dorsal vein and to expose the urethra. Try to remove the tumor or prostate as adequate as possible. Now we see the Foley's catheter in the urethra. This is a cutting of the urethra. After cutting the urethra, the prostate will be totally removed. The treatment for intermediate risk disease, active surveillance is not suggested any longer. Operation is one of the definite treatment. Radiotherapy alone is not as curative enough. Androgen deprivation therapy, ADT, for 6 months must be added to decrease the recurrence rate. High-intensity focused ultrasound technology and cryotherapy could still be offered. However, multiple disciplinary approach, that is, radical prostatectomy with extended pelvic lymph node dissection, adjuvant or salvage radiotherapy, and androgen deprivation therapy. These 3 treatments may be needed for better outcomes, but wrong sequences will increase the complication and jeopardize the functional outcome. For example, urine incontinence and sexual dysfunction will be severe after salvage radical prostatectomy, and sometimes after salvage Pai-Fu. This is the picture of Pai-Fu. The probe is located in the rectum. The energy was delivered by the transrectal probe under sonoguide. This is prostate, this is urinary bladder. Just like putting a magnifying lens under the sun, we can focus the energy to destroy the prostate tissue. For high-risk prostate cancer, operation alone may not as curative enough. Multidisciplinary approach, radical prostatectomy with extended pelvic lymph node dissection, adjuvant or salvage radiotherapy, and androgen deprivation therapy must be considered as the standard of care. Radiotherapy must be accompanied with androgen deprivation therapy, at least for 2 to 3 years. And because of the multiple treatment sequences and adverse events should never be neglected. There is a notable point: never give androgen deprivation therapy alone, except primary site treatment is not feasible. Otherwise, the chance of developing castration-resistant prostate cancer will progressively increase. For those treatment goal of cure is no longer possible, the aim is life prolonging. The treatment of non-metastatic castration-resistant prostate cancer, so-called NM-CRPC, metastatic castration or hormone-sensitive prostate cancer, so-called AM-CSPC or AM-HSPC, must be tailored to get the longest duration response and the least adverse events. Of course, finally, all these cancers cannot be cured will develop into metastatic castration-resistant prostate cancer, so-called M-CRPC. Until these phase, patients used to receive more therapy, but more and more evidence show upfront therapy rather than sequential therapy will offer better outcomes. Not to mention about small cell carcinoma or neuroendocrine differentiation, adenocarcinomas of prostate are mostly endocrine, androgen dependent, and androgen receptor dependent. After a certain period of androgen deprivation therapy, the clones of intracrine and maybe paracrine cancer cells become the majority, and they are still susceptible to novel hormone agents. When there are only androgen and androgen receptor independent cancer cells left, drugs of other mechanisms should be used. Of course, androgen deprivation therapy must be lifelong, or just let patients receive orchiectomy. Medical castration is usually achieved with the administration of luteinizing hormone, gonadotropin releasing hormone, so-called LHH, GnRH agonist or antagonist, at the castration level of testosterone less than 50 nanogram per deciliter, or even better, 20 nanogram per deciliter. Bone protective agents such as bisphosphonate and denosumab with vitamin D supplement should be given to prevent or delay skeletal-related events. The first generation anti-androgen provides no further survival benefit and is useful only at the testosterone flare-up period by initial gonadotropin releasing hormone agonist boost, such as steroidal cyperteron acetate and non-steroidal flutamide, nilutamide, and bicalutamide. Novel hormonal agents have found significantly improving survival and delay progression. Now we have abiraterone acetate for metastatic castration-resistant prostate cancer and metastatic castration-sensitive prostate cancer, enzalutamide for all, and apalutamide, darolutamide for non-metastatic castration-resistant prostate cancer and metastatic castration-sensitive prostate cancer. Drugs of other mechanisms than androgen axis are now the last but not only hope of prostate cancer. We now have chemotherapy of docetaxel, cabazitaxel, PARP inhibitor, such as olaparib, rucaparib, and niraparib, radium-223, 177 lutetium-labeled PSMA radioligand therapy. Pembrolizumab is one of the immune checkpoint inhibitor. This drug can be used for metastatic microsatellite instability, so-called MSI high, or mismatch repair deficiency, dMMR, prostate cancer. Because of the genetic characteristic, this drug can make a great help for those cases. Again, sequential therapy and the combination therapy is now the trend. You can use double or even triple combination. More and more noteworthy trial with upfront therapy may provide even longer survival than traditional sequential therapy. All these approved drugs are based on solid study with appreciable overall survival benefit, from chemotherapy, novel hormone therapy, radiotherapy, and PARP inhibitor. Although we have so many therapeutic options now in metastatic castration-resistant prostate cancer, but we know patients with advanced prostate cancer always died of castration-resistant status. The key points are to delay castration resistance and prolong the duration of treatment response as long as possible with acceptable adverse effects. We can use those treatments independently or combination to get the best benefit. So as you can see, it's very complicated. It is really an art to use the right drug or treatment for the right patients at the right time. With comprehensive knowledge, significant and aggressive treatment, prostate cancers can be treated like chronic diseases. It's the end of my talk. Hope you all enjoy it. Thanks for your attention.